This is also important in cases of the tuberculosis because the organism will go to this area. So GI TB is a little uncommon. The common one is the pulmonary TB, but still it occurs due to two reasons we'll discuss later. Although any portion of the GI may be affected, but the terminal ileum and the cecum, as we discussed, are the site most commonly involved, and we can feel the mass in this area. So during palpation of the abdomen, if we find a mass in the right iliac fossa, that can be due to the GI tuberculosis, and that mass is predominantly due to the fibrosis caused by the disease. So the infection can be of two types in GI TB. It can be primary or it can be secondary. Primary is when the organism is directly reaching to the GIT. So it can be due to Mycobacterium bovis, bovine tuberculosis, by the infected milk or unpasteurized milk. That is why we have adopted the rapid sterilization method that is known as pasteurization. And the secondary infection is due to the infection in the body somewhere else, and the GIT is getting infected in the later stage. That is secondary tuberculosis. So the most common is pulmonary tuberculosis, and as per we can say the stigma of spitting outside, the person generally swallow the sputum, and that sputum is having the mycobacteria in it, and that infects the GI tract. So that is the secondary infection that is caused by the Mycobacterium tuberculosis. So the organism is different in primary and the secondary. Primary is mainly bovis and secondary is mainly tuberculosis, Mycobacterium tuberculosis. So the tubercle bacilli, either bovis or tuberculosis, is protected from the gastric acid by a thick wall of the bacteria. I think you must have studied this organism in microbiology. It has a thick cell wall. That is why we do the acid fast staining. We pour the heated acid on it, heated carbonyl fusion, so that it can penetrate through its wall. So it gives protection to this bacteria from the acids also by the waxy capsule and passes through the intestine, go to the small bowel. Then it establishes a locus of infection. Usually, that is 90% of the patient, the lesion is ileocecal region, where lymphoid tissue is abundant. Although infection can also occur in colon, jejunum, appendix, or anywhere in the GIT. So these are the risk factors for active tuberculosis in a person who have been infected with tuberculosis. So the pathogenesis is like that: when a person is infected by the bacteria, it goes into the body and stays dormant. It is not producing any disease in the initial phases, but there are many factors which may aggravate the disease or which may reactivate the bacteria. So the list is long: recent infections, fibrotic lesions, comorbidities like HIV infection, silicosis. So HIV is a very important cause because it causes reactivation of the tuberculosis. So generally the tuberculosis and HIV are found together because most of the people in our country are infected by tubercular bacilli. Any point of the time in the life, they are infected with it. But when the infection is there, HIV infection is there, the infection gets aggravated and patient presents with the tubercular features also. Then silicosis, chronic renal failure, diabetes, all of these are a bit of immunodeficiency disorders. Excessive alcohol use, immunosuppressive treatment, tumor necrosis factor alpha inhibitors, then gastrectomy Post-transplant, where we give the immunosuppressive drugs, tobacco smoking, and malnutrition, where the immunity decreases. So, the crux is whenever the immunity is in decreasing phase, it causes reactivation of the tubercular infection which is already present in the body. So, this is the cycle of the bacteria, how it produces infection or how it produces immunity also. So, when the mycobacterium enters, there is a mannose antigen or C3b on the cell wall, which binds with the mannose receptor on the macrophage, and that bacteria gets internalized into the macrophage, where it fuses with the lysosome, and here it proliferates. And when this cell ruptures, this bacteria spreads all over the body, giving a bacteremia picture. This bacteria is all over through the blood. But simultaneously, it produces immunity also. So when there is next infection, so alveolar macrophages come and bind with the T cell, and this T cell acts in the lysis of the bacteria which is present in the macrophage. But during this phase, during this lysis, we can say a fight occurs and there is a death of cell. So many cells die and causes necrosis, and many cells recruit themselves around that dead tissue. So macrophages are all around that necrotic lesion, and that macrophages get converted into epithelioid cells, and some of these cells coalesce to form a large cell that is called the giant cell. So the lesion is central necrosis surrounded by the macrophages, and the modified macrophages are epithelioid cells, and multiple epithelioid cells form the giant cell. So there are giant cells, lymphocytes. So that whole of the lesion, which is composed of all these cells, is known as a granuloma, that is caseating granuloma, because it has a necrosis in the center, caseating granuloma formation. So we can write it like this: Mycobacterium tuberculosis goes into the human host, alveolar macrophages phagocytize the bacilli, then there is a formation of phagosome, adhesion of the mycobacteria to the macrophages results largely from binding of the bacterial cell wall to a variety of macrophages cell surface molecules, as we discussed, mannose receptor and C3. Then there is bacterial cell wall lipoglycan lipoarabinin inhibits the intracellular release of calcium. This is a specific characteristic of the Mycobacterium tuberculosis, which inhibits the secretion of this calcium. And this calcium was important in the lysis of the bacteria. So if the bacteria inhibits this process, it protects itself. Bacteria protect itself from the lysis, acting via calcium. At the same time, this bacteria also inhibits the production of phosphatidylinositol 3-phosphate. Again, these are all the protective mechanism of bacteria. Bacterial factors block the host defense of autophagy. Then bacilli are successful in arresting phagosome maturation and replication. So by all these methods, the bacteria is protecting itself from the immunity factors of the body. Again, the recent research has shown that NRAMP1 on chromosome 2q also plays a role in the susceptibility of the tuberculosis in a specific person. So in the initial stage, host bacterium interaction, Mycobacterium tuberculosis disseminates after rupture of the phagosome and undergoes a period of extensive growth within naive unactivated macrophages. Wherever this bacteria will go, it will infect the phagosome and there it will proliferate. Then additional naive macrophages are recruited to the early granuloma. Then chemoattractants and bacterial products released during the repeat rounds of cell lysis and infection, they again attract many macrophages and the dendritic cells, which will produce this cell to the immunity system. So these dendritic cells migrate to the draining lymph node and present the mycobacterium antigen to the T lymphocyte. That is why the immunity in this disease is predominantly cell mediated. So wherever there is a decrease in cell mediated immunity, there is activation of the disease. So after 2 to 4 weeks of infection, two host responses in the body develop against the Mycobacterium tuberculosis. First is macrophage activating response. It's a T cell mediated phenomena which leads to activation of macrophages and killing of the bacteria. And the other response is tissue damaging response. So it is the result of delayed type hypersensitivity reaction to various bacillary antigens. So tissue damaging response is a DTH. This question can be asked. It's a delayed type hypersensitivity reaction, and it destroys the unactivated macrophages that contain multiple bacilli, and that can cause the necrosis, as we have discussed earlier also. So finally, the qualitative and quantitative defects of CD4 positive T cells, which are responsible for the T cell immunity, this explains the inability of the HIV infected individual to contain the Mycobacterium proliferation. So that is the most common investigation in the HIV patients. We go for the CD4 CD8 cell count. So this CD4 cell count determines how the infection will proceed in the person who is infected with the HIV. So with the development of specific immunity and the accumulation of large number of activated macrophages at the site of infection, granuloma formation. Here we can see the granuloma. We will see this lesion in, I think on Friday you have a practical, so we will studying the intestinal tuberculosis slide. Here we can find the central area which is having a caseous necrosis, granular necrosis, which is eosinophilic and surrounded by some cells. They are also having large cells, that is giant cells. And if we go for the special stain and then these giant cells, we can find the Mycobacterium tubercular bacilli. So this necrotic environment again protects the bacteria because there is no cell and no oxygen. So this environment gives protection to the bacteria and increases its growth also. Now in the fate of the lesion, some of the lesion may heal with the help of fibrosis, later on calcification. So in summary, injection of the infected milk, entry of bacilli into the mucosa, then granuloma formation, then caseous necrosis. This may spread all over the body or ulceration can occur on the covering mucosa. So what happens by this lesion? So they can form an ulcer, and the quality of the ulcer is that it is in the transverse plane of the bowel. The other ulcer can be in the longitudinal plane. So if it is transverse and is getting healing by the fibrosis, there will be constriction of the wall, which will produce the intestinal obstruction. So subacute intestinal obstruction is a feature of the tuberculosis, which give rise to napkin ring like structure. As this bacteria is going into the lymph nodes, so these lymph nodes gets enlarged. So lymphadenopathy, intestinal ulcer with constriction and associated with the mesenteric lymphadenitis is a classical triad of the tuberculosis. Now, granulomas can occur in all the layers of the bowel wall, especially in the Peyer's patches. We saw in the first picture where there was lymphoid follicle in the wall. So what can be the clinical feature of the disease depending on such lesions? It may give rise to the abdominal pain, which is more or less similar to the appendicitis. Then it can be associated with the intermittent diarrhea or swelling or the obstruction, as I discussed, subacute intestinal obstruction. Hematochezia is the presence of, what is hematochezia? Blood in the stool. Hematochezia is blood in the stool, which may be oozing through the ulcers formed by the bacteria and the palpable mass in the abdomen. And constitutional symptoms as can occur in tuberculosis of any part of the body, which is fever, weight loss, anorexia, and night sweats. These are the constitutional symptoms of the disease. The most important differential diagnosis for the disease is Crohn's disease, which also give rise to the formation of granulomas in the intestinal wall, but those granulomas are non-necrotic. And simultaneously, there is involvement of the muscle layer, which can give rise to cobblestoning of the mucosa, which we will study in the IBD class. So what can be the different types of intestinal tuberculosis? It can occur into three forms. First is ulcerative, which is the most common form. Then hypertrophic or hyperplastic type. And third is the mixture of both, ulceroproliferative or ulcerohypertrophic. So on the gross examination, what can be the finding? As we discussed, ulcer, growth, constriction. So the lesion in the secondary intestinal tuberculosis begins as a small ulcerative lesion, which later enlarged to form a large transverse ulcer. Mind it, this is important. Transverse ulcers are found in tuberculosis. That is, the ulcers are perpendicular to the long axis of the bowel. This is because of the spread by the lymphatics. The opposite to this is typhoid ulcer, which are the longitudinal ulcers. So we can differentiate these two ulcers on the basis of the direction. On the gross examination, serosal surface can show the presence of tubercles, large nodules, which is a small elevation or protuberances on the serosal surface. Later stages, stricture of the small intestine, mind it, small intestine. Large intestine has a big lumen, so there the stricture is not common. The strictures are common in the small intestine due to the fibrosis. Long-standing lesions may even show napkin ring-like construction. Lymph nodes, mesenteric lymph nodes enlarged, and in hyperplastic type of tuberculosis, the cecum is primarily involved. Sometimes ascending colon, the wall of the cecum is thick and sometimes form a mass lesion because of the granulation tissue, which can be palpated through the perabdominal examination. So this is a mixture of ulcero-hyperplastic lesion in the cecum. The ulcer is present on the site of the arrow, and we can see the thickened wall of the intestine. So it is a ulcero-hyperplastic type of growth in the cecum. Here we can see the thickened wall along with the growth and presence of the tubercles. We'll see the tubercles in the next picture. This is the external surface of the intestine. Here we can find tiny nodules on the surface. These are due to granuloma formation in the wall. So on microscopic examination, as we discussed, what can be the finding? Mucosa shows ulceration, granulomas, which we have seen already, can be caseating or non-caseating also, but predominantly these are caseating, and we identify this by this feature only. So in some instances, a non-specific diffuse chronic inflammation with fibrosis without granuloma is seen. Granulomas may vary in the size, and the periphery of the granuloma may contain mixture of lymphocytes, plasma cell, and Langerhans type of giant cell. So after staining with the AFB particular stains, we can see the multiple bacteria also in these macrophages. So is again the picture of granuloma. Here we can see this slide you will see on Friday. How to identify? There are two slides in the practical hall. One is TB lymph node and other is TB intestine. And out of these two, you can get any one of that. So to identify it's an intestinal tuberculosis, you will have to see the mucosa. If the mucosa with the glands is present in the upper part, that is an intestine. Then in the submucosa, we will find the well-defined granulomas made up of necrosis, giant cells, epithelioid cells, lymphocytes. Okay. Again, the mucosa is intact. We can see the glands. and a granuloma, well-formed granuloma with the Langerhans type of giant cell. So complications by this disease, tubercular peritonitis. Either the direct spread of the bacilli from ruptured lymph node or the hematogenous spread, which may give rise to non-specific abdominal pain, fever, and ascites. When we retrieve the fluid from the ascitic fluid, when we retrieve from the peritoneal cavity, we can find the large number of lymphocytes along with the high content of the protein, which is diagnostic for the tubercular effusion. And we can prepare a smear by this fluid and stain it with the AFB stain and can see the bacilli. Stricture is due to the fibrosis, which may result in the intestinal obstruction. Sometimes the perforation can occur, but it's a rare phenomena for tuberculosis. Few lines regarding HIV associated TB. As we discussed, it is due to the decreased cell mediated immunity, CD4 cell count decrease, so the activation of tuberculosis occurs. So TB is one of the most common disease among HIV infected persons worldwide. It is responsible for estimated 20 to 25% of all HIV related mortality. This is important. HIV mortality, that too in the range of 25%, is due to tuberculosis. A person with a positive TST who acquires HIV infection has a 3 to 13% annual risk of developing TB. So the person is having tubercular bacilli in the body because the test is positive. Skin test for the tuberculosis, which we say is the Montu test. If the test is positive, which means there is presence of infection inside the body, but at the same time we have a immunity. So when this immunity decreases due to HIV, there is reactivation of the disease. So the immunity, as it decreases, there is a very low chances of healing by the treatment, and generally these bacteria are multi-drug resistant. So this is immune reconstitution inflammatory syndrome, IRIS, or the TB immune reconstitutional disease. This is exacerbation in systemic manifestation like lymphadenopathy or fever or respiratory signs, as well as laboratory or radiographic manifestation of the TB. It is associated with administration of ART. ART is antiretroviral therapy and occurs in 10% of the HIV infected TB patients. So it's a syndrome associated with HIV patients having the treatment. The flaring of the response. How can we detect the tuberculosis? First of all, as I told you, we are in India, so we should have a high index of suspicion. PUO. What is PUO? Pyrexia of unknown origin. So it's a diagnosis because we are not reaching to any specific diagnosis. So we mark this case as a PUO. So in India, if you are having a PUO for a longer duration and no diagnosis can be made, we can start antitubercular therapy just on the basis because the incidence is very high. So we should have a high index of suspicion and the typical symptom of the disease. We can detect it with the help of NAT, nucleic acid amplification testing, that is gene expert, or the LAMP, loop mediated isothermal amplification. Here we amplify the bacteria and detect it. The easiest way is AFB microscopy, then mycobacterium culture. In the MGIT system, these are the specific bottles in the system to increase the growth of this bacteria. And the mediums which we use in this culture is LJ media, Lowenstein-Jensen medium. There is again a question. LJ medium is used for the growth of the tubercular bacilli. And it is incubated at 37 degrees centigrade under 5% CO2. Then when the bacteria is detected, we can go for the drug sensitivity just for the sake of the treatment. So there are 5 primary drugs for the disease and others are the secondary drugs. Radiographic procedures, there is widening of the ileocecal angle, also known as pulled up cecum on the barium radiography, and the filling defect in the ileum just because of the constriction. So here we can see the acid fast bacilli, which is having a specific color due to carbonyl fission. Here we can see the pulled up cecum by the barium studies of the intestine. Few more pictures of the barium study. Multiple constrictions can be seen in the intestine. The thing is that we are latently infected with tuberculosis, so it is important to diagnose that also. So the first test which we discussed is tuberculin skin testing. Here we inject the tuberculin units in the intradermal area, and there is a reaction from the body if the person was already infected and is having a cell mediated immunity. Those cells which I told you, CD4 cells along with the macrophages, go at the site of the infection and produce a lesion. There is a, you can see the induration is present. The skin elevates from the normal level. So by that we can identify the person is either infected or not infected. And the second one is interferon gamma release assay. Nowadays it is very common because it's a, you can say, non-invasive and non-subjective also, because in that case tuberculin testing, there are two things which are subjective. First is the injecting of the TU in the specific site. If that is not injected at the right place, that granuloma will not form. And the other is reading of this induration, which is at the 48 or 72 hours, 48 to 72 hours. So if the person misses that duration, the granuloma subsides or the induration subsides. So to get rid of these two problems, we are going for that interferon gamma release assay. Here we collect the blood in the specific tube where the cells are there and they release the interferon gamma, and that interferon gamma is then later on analyzed or the levels are diagnosed. So in vitro assay that measures T cell release of interferon gamma in response to stimulation with the highly TB specific RD1 encoded antigen. But the thing is that you can see in the third line, it cannot differentiate between active TB and latent TB. You should all keep in your mind, if interferon gamma testing is positive, it is not a diagnostic test for active or the latent tuberculosis. The thing is that if it is negative, then you are sure the patient is not infected. But if it is positive, he can be having a latent infection or active tuberculosis. Skin testing, which we have discussed, it is due to the CD4 T lymphocyte. This is important. CD4 T lymphocytes. If it is deficient, like in a case of HIV, in the later stages, when the immunity is low, the patient may have infection by tuberculosis, but the TST will come negative. So that is the false negative. False negative. This is the method. We are injecting on the forearm, ventral aspect. We make a circle around the lesion where we are injecting and ask the patient to come after 48 to 72 hours for the reading of this induration. And then we measure with the help of the scale what is the extent of this induration. So treatment, first of all, we try it with the medical treatment, but if there is obstruction and it is non-responsive, then we can go for the ileocolectomy. So that's all for the intestinal tuberculosis. Any questions regarding that? I have few just to discuss the case. Which of the following is the commonest site of intestinal tuberculosis? Here we have both the options: ileum, colon, jejunum and stomach. Cecum is a part of colon or not? So ileocecal junction, as we discussed in the earlier slide, ileocecal junction was the most common, so we will mark it as a colon. because it is in the proximal part of the colon, that is the cecum. Here is the most common lesion. Then transverse ulcers are seen in typhoid, tuberculosis, amoebiasis, or ulcerative colitis. Tuberculosis. The other one is the typhoid, where we have a longitudinal. So, in a study that examines granuloma formation in the lung in response to infection with Mycobacterium tuberculosis, it is observed that some cells within the granuloma express MHC class II antigens. These class II antigen bearing cells are most likely derived from which of the following peripheral blood leukocyte? Basophil, CD4 positive B lymphocyte, monocyte, NK cells, and neutrophil. Macrophages are of the line of monocyte. We combinedly call it monocyte macrophage system. So they develop from the monocytic lineage. False about intestinal tuberculosis. False. Hyperplastic variety has colonic strictures, raised markers, anemia, positive sputum culture points towards diagnosis. Barium meal follow through shows pulled up cecum, and interferon gamma assay is diagnostic. So what is false in this? No? No response? Okay, we'll leave it like this, because if you are not interested in knowing the answer, not attempting, then no need to tell. Okay? Thank you. Attend